Hi everyone, my name is Melanie Grant and this is C&M Glass. This video is being recorded to review for ICD-10-CM coding for inpatient services, some of the specific rules and requirements that we have on our board here, and outpatient HCCs. So this video is really going to be looking at a lot of the section guidelines and how we apply diagnostic coding for inpatient services, all while we talk about tracking different kinds of information for payment and how that also is very similar to HCCs found in outpatient world. So our key points, well, we have two big ones, inpatient coding and HCCs. But before we get down to our HCCs, we'll be talking about the different types of inpatient coding, what to do with uncertain diagnoses, how to identify your codes that are present on admission, hospital-acquired conditions, DRGs and UHDDS. So let's get started. There's a lot of terms that are reviewed in this particular chapter, and we're going to be using our Let's Code It from McGraw-Hill Connect 2019 edition. In addition to this textbook, we'll also be looking at the ICD-10-CM 2019 Expert Edition from the AAPC. So both of these will be referenced in page numbers, although you can use any of your ICD-10-CM coding books so long as it's a 2019 edition. However, there may be slightly differences in some of the additional resources that we're going to be looking at, and you may or may not see similar page numbers. So just kind of getting started, the first thing to talk about is really what is inpatient coding? So most people think, okay, well, inpatient coding is when you're in the hospital. And while that is true, there is a rule on what makes them inpatient, and your keyword is an admission. A lot of times people think if a patient is in a hospital setting, that means that they're immediately inpatient, and that's not always the key. Now, when you're doing ICD-10-CM coding, we don't pay attention to specifics like was this a facility bill or was this a professional bill, because the ICD-10-CM is listed the same on either one. But the rules for whether or not they were admitted do change exactly how we're going to select our diagnosis. So just to kind of refresh your memory, there's something called a 2 midnight rule, which is established for Medicare, that basically states a patient is only considered inpatient or admitted if they are in the hospital under an admission status for 2 or more midnights. So if they come in on Monday, let's say at 8 a.m., they have to stay past midnight on Monday night and past midnight on Tuesday night before they are considered inpatient admission. If it's less than that, then they are observation, emergency room, they're maybe in the surgery. It depends on what department they're in, but they would not be considered inpatient. And so the first thing you must do when you're looking at a code or coding for inpatient services is to verify that they are in fact inpatient. Now, that being said, there's two different types of inpatient coding. There's concurrent coding, which is done at the same time that they're in the hospital. So a lot of times, the downfall of this is that the diagnoses themselves may change throughout the course of the hour. And it's important that we capture the correct information each day, not just each hour. So at the end of the day, what was the most relevant item of what was being treated and cared for by the provider that you're coding for. But if you code too early in the day when you're concurrent, when you're coding alongside of them being admitted, then you could end up having errors that you later have to submit corrections for because you could have missed revenue or just incorrect information. The secondary option is to code at discharge. Once the patient is being discharged from the hospital, they're being released, they can go home. Some offices will code the entire note for all of the services. Well, the downfall to that one is that if the patient is in the hospital for months at a time, and that can happen where a patient is in there for a month and a half or 2 months, then you may end up having services that are past the date for being submitted or inappropriate to document at such a later date. Provider information has changed so much over the course. So it's really important to follow. This is a policy that your office is going to have set. So it's really important to follow whichever that is. Make sure you look at the notes for the visit you have. keep in mind that whatever the diagnosis is listed, the note that you are coding for is the most relevant regardless of how it changes. Okay, so let's talk for a second about how we identify some of the guidelines. In your ICD-10-CM book, you'll find guidelines for inpatient coding actually are starting on page 30 of this edition or section 2 of your ICD-10-CM official guidelines. Section 2 is where you're going to find all the information about selecting your principal diagnosis. And this goes into some of the details like uncertain diagnoses. I have it open in front of me. How to identify when there's more than one condition that's just as equally important and focused on. If they contradict, how to identify when coding signs and symptoms. And some of the guidelines about admissions from observation, admissions from outpatients, or other facilities. So these guidelines are very important to review and be familiar with because they're going to help you really identify how to select inpatient coding. So rule number one, maybe not number one in the guidelines, but rule number one to keep in mind is that you're going to code everything as if it happened. Now let me explain that just a little bit. If we know something didn't happen, such as a condition or a suspected illness, we're not going to code it. But when we're coding concurrent services, we may not have the results from labs in. And while it's important to have those results in for outpatient coding before we can say the results, in the inpatient world, one of the guidelines, and I'll read it to you, talks about if a diagnosis is documented at the time of discharge, okay, so this one's not a concurrent, but at the time of discharge, if it is qualified as probable, suspected, likely, questionable, possible, or still to be ruled out, or other similar terms including some indicating some sort of uncertainty from the provider, we code the condition as if it existed or was established. Now, that's completely against everything we've learned. It goes against the golden rule. If it wasn't documented, it didn't happen. And if they're documenting, they don't know, they're not saying it did happen. But this is one of the only times you're going to have something really funky like that. It's the only time we go against the golden rule. If they say it's probable or suspected in the documentation for the visit, when they're inpatient, they do all the workup and all the treatment as if the patient had the condition they're suspecting. And because of that, it costs more money for the provider to do those services, and that money should be reimbursable. Okay, and we'll talk about how reimbursement works in a minute and why that's important. According to our guidelines, though, the basis is that diagnostic workups, arrangements for further workups and observations, an initial therapeutic approach that correspond most closely with the established diagnoses is the reason. It's applicable only to inpatient admissions to short-term, acute, long-term care and psychiatric hospitals. So keep that in mind when you're looking at this, and we'll talk on our next video about signs, symptoms, and what to code when it's probable in an outpatient setting. But in the inpatient setting, if we suspect a condition or indicate any uncertainty, it gets coded as if it exists. And that is going to be all based off of the documentation of what is suspected. There's still no assumptions as to the detail of that, okay? So, now that your mind is blown on that, in order for us to identify our principal diagnosis, we have to list a couple of different things. We look at what is the major focus for the visit. We have guidelines for 2 or more interrelated conditions which each possibly meet the definition of a principal diagnosis, or 2 or more diagnoses that equally meet the definition of diagnoses, and 2 or more comparative or contrasting conditions. Now, there's a lot of different guidelines in here. It's important to read through these. But one of the important things you want to identify is what's present on admission. That's this one right here. Okay, so what did they come in with? What was the problem? And did we identify a sign or symptom that then was diagnosed, or was it still uncertain? And if it was uncertain, was it uncertain but suspected to be a specific thing? So we go back to that coded if Code as if it applies if it's indicated as uncertainty. But when we talk about our principal diagnosis, our principal is very similar to the outpatient word primary. It's the main thing that the patient was seen for, and when the case of multiples apply, then we identify which one is the more relevant in terms of care, and that falls under DRGs that we'll talk here in a minute. If a patient is receiving services from your provider specific to certain conditions they have, but not the entire hospital visit, it's important to identify what that provider is treating. So oftentimes you'll read in the note, and you'll have something like a soap or a meat. And in the A section of your note for either of these is your assessment. This is what the provider is seeing them for and what is consequential to their treatment. On present on admission, this is very important. So present on admission means which of the diagnoses that you're listing did the patient have when they got admitted to the hospital. So we want to identify things like diabetes that may affect the care throughout their entire time, and say, did we know that they had diabetes? Like, even if we didn't know, did we determine that they had diabetes when they were admitted? Yes, diabetes most likely was something they had when they were admitted. Patients with pneumonia. Did they have pneumonia? Is that the reason for admission? Was it present on admission? Or was it something they received in the hospital? Because if we can't determine if it's present on admission, it falls under to these HACs. And HACs are no good. Those are hospital-acquired conditions where the patient gets sicker because they're in the hospital while they're getting treated for something else. Now, it happens a lot, and there's a lot of reporting, there's a lot of research, there's a lot of guidelines, and this is how we identify things that are common or that are concurrently running through our hospitals. It's good to have these kind of resources and this review. And in order for us to identify these HACs, we have to identify the present on admission. So, when you're listing a diagnosis code, there's an indicator called a POA indicator where you'll list a one-digit letter or number to say, yes, it was present on admission, no, it was not, U, meaning it was unknown, W, meaning it was not able to be determined, or 1, meaning that it was clinically exempt. And in your book, we talk a little bit about that information. And under 1, you'll find that exempt, it gives an example of newborns and moms that are giving birth. So that would be an exempt condition because it's not a problem that they're being seen for. It's a birth, it's happy things. And we learned all about newborns and moms in our recent videos. So kind of going forward, when you're looking at the POA indicators, you have to identify all information based off of what's in the note. And you're going to find that in your first section of your soap or meat note, your S for subjective, and your M for your monitor, which is where they indicate any signs and symptoms that they're monitoring or that they've reviewed within the note. That's typically where you're going to find it, although you may at times find it under your observation or exam section. So our soap note and our meat note are very much the same thing. And I put those both up there so you could reference those. Okay, so why is it so important that we know this information? One of the important things with inpatient coding especially is we track a lot of information based off of how good the provider is, how good the hospital itself is, whether or not they have a lot of unnecessary or unusual hacks within their facility, whether or not patients are returning to the hospital after being discharged. A lot of this information tells us about our hospitals, whether or not they're good, whether or not the providers are giving the proper and adequate care. And as we are learning about medicine and constantly recreating our diagnoses, charge captures, and diagnoses, it's important that we evolve with this information, that we take it. This is where we get our information about what treats certain illnesses. How long is a prognosis or an expected course of a disease to go? Is this patient terminal? Are they looking at something that may kill them? These information is all put together from various types of research and information that are being done on a regular basis, looking at medical coding to determine what's going on with the patient. Now, a lot of this is captured in what we call our DRGs. Okay, so our DRGs is in a lot of ways a payment system for Medicare-based Medicare providers. Let's see if I can get that right. If a provider, or the hospital if you will, is a participating provider with a Medicare payer, either through Medicare or maybe one of your senior plans, oftentimes they're going to see that there's DRGs specific to how they get paid. So, unlike most coding where we get paid for the services we do, the DRGs are these diagnostic related groups where Medicare comes in and says, this type of diagnosis is worth this much money throughout the course of its hospital stay. Okay, seems pretty easy. So let's talk about an example then. Let's say you have a patient that's admitted with asthma. Okay, now if the provider lists that they have asthma, and I'm going to actually go into my asthma coding here as we're talking, because I can give you some of the code examples which we'll be learning when we talk about respiratory coding later on in section 3 of our class. So asthma is going to be classified in our J section. And I'm going to go over there now to J45 in my ICD-10-CM book. And there's a reason for my madness, I swear. All right, so asthma is a very large section. In fact, if you look at the different areas, asthma by itself has a lot of includes notes. It includes things like allergic bronchitis, allergic rhinitis with asthma, atopic, meaning without problems, extrinsic, hay fever, idiosyncratic, intrinsic, non-allergenic, and just regular non-allergenic asthma. And then there's additional codes that identify different information such as tobacco history, if they are a current smoker versus a former smoker, occupational hazards, and use. But it does have a couple excludes, such specific types of asthma like detergent, eosinophilic, minors, wheezing, wood, and then asthma with chronic obstructive pulmonary disease, chronic asthmatic obstructive bronchitis, and chronic obstructive asthma. So let's say that your provider saw the patient, did a lot of information because the patient has asthma, and you get this 10-day hospital visit for asthma. Asthma by itself, unspecified as to the type or complication, would fall under code J45.909. And I don't have the exact DRG weight for this, but let's say that that weighs that gives them 2 points. So when we're talking about DRGs, each of the specific DRGs has a weight where they say this diagnosis code is worth so much money, and here's the weight, and they calculate. They have all these cool and weird calculations I prefer not to get into in this class, but we'll talk about those in the future. For now, just know that J45.909 is worth, we're presuming it's 2, okay? But if you'd looked in the note, maybe you saw that the patient had COPD with asthma. Okay, so asthma with chronic obstructive pulmonary disease. Which is J44 dot, and it says .9, but we're going to go verify that. So I look at J44, other chronic obstructive pulmonary diseases, and I have the options between Okay, so let's, before we read through that, let's say they had COPD with asthma and for a time when they were admitted, respiratory failure. And the provider hacked it all up due to asthma. Now, when that happens, the difference in the code here, we're going to get COPD with obstructive pulmonary disease and with asthma, which is a much more serious condition. And let's say the basic code for that is .9, which is, let's say, worth 3 points. And again, that's not an actual DRG, I'm just giving an example. But if we looked at the actual diagnosis and saw the specificity options, you have J44.0, which is chronic obstructive pulmonary disease, COPD, with acute lower respiratory infection, and COPD with acute exacerbation. Okay, so if they had asthma with respiratory failure, you would look back into the note and see, does it say something about exacerbation? If they have acute respiratory failure, there better be something about exacerbation. So any kind of indication that it is exacerbated would fall under this. So now instead of J44.9, we're going to find ourselves at J44.1. And also, anytime you have something like a respiratory failure, let's say that's worth a 4.5 because that's a pretty serious condition. But anytime you have something like respiratory failure, you now add an additional diagnosis for that respiratory failure. So I'm going to look in my book real quick for failure because that is my key or main term. That is the problem itself. And it takes just a minute to look these up. Okay, so I found failure, and I'm on page 170 of my alphabetical index, and I'm going to look for respiratory, heart, QRS. Of course, I always have to do my notes in my head. Okay, and so I found respiration and respiratory, which is basic code is J96.90. It doesn't mean that's going to be our code, but that's the suggested code. And when we look at this, we have a lot of widths, acute types, acute width, acute on chronic, chronic, newborn, post-procedural, and different variations of that. So I would imagine that somewhere in your note, you found that they had hypoxia, which is J96.91. So we'll kind of look at both of those. So again, we have to verify in the note. We're going to find that information somewhere in that SOAP or MEET. Most likely at the point where we're talking about COPD with asthma and respiratory failure, that's either in the subjective, the objective, because the assessment was just asthma, or the monitoring or evaluation. So that first two halves, the part where they're collecting information or the part where they're observing it. And so at that point, we're going to go and we're going to find J96. And we're almost done here, I swear. Try J. J96.91. Okay, and so I look at J96, respiratory failures, not elsewhere classified. I verify my excludes that it's not going to be excluded when it's done with COPD, which it is not. And then I see J96.0 for acute respiratory failure, 1 for chronic, 2 for acute and chronic, and 9 for unspecified. Now, if it is identified, even though this was originally a chronic condition, if the respiratory failure is identified as acute respiratory failure, then we would make sure, so this is one reason we always read up and down. We would make sure that we get the more specified code because that's going to have a stronger DRG. And let's say we go back and we looked at it and it did say acute. And so we're going to say, okay, acute respiratory failure, J96.0. So now we are going to just kind of erase our little markings here. That's why it's always good to have like a little scratch pad. .0. And then I have the options between 00, 01, and 02, which is the differences of unspecified, whether hypoxia or hypercapnia was involved, versus with hypoxia and with hypercapnia. And we did say with hypoxia, so that's going to be J96.01. And let's say that this by itself is worth another 3 points in the DRG. At that point, we've selected 2 codes instead of that asthma code, which are then worth, according to this estimated DRG, not a real one, 7.5 versus 2. So if you think about it as every code that you select is worth information, the unspecified asthma code doesn't give us a lot of detail. But when we get into the actual reason why the patient was here, especially in an inpatient stay, we can support the documentation and the information needed by talking about the types of chronic conditions they have, how it exacerbated, what it also had. And this is going to take us into our last topic, but before I get there, the difference between DRGs and HCCs, very similar, different types of codes, different types of coding for outpatient, but they all mean how we get paid and different incentives for our hospitals, how we're recognized, how our tracking is done, and how our providers are identified as good providers or providers lacking and needing instruction. Okay, so the last 2 parts of our chapter that we want to talk about with inpatient coding all falls into this. The first being complications and comorbidities, and you saw that I kind of picked up on this here. So this example that we had here of a patient who was seen for asthma, but in reviewing the note, we found that they had COPD with asthma and with respiratory failure. So in the instance where there's comorbidities or complications, we're talking about things that also affect the patient other than why they're being seen in this moment. So in this moment, they may be seen for COPD with asthma, but maybe they have other conditions that affected the type of treatment, such as our diabetic patients who can't take certain medications, hypertensive patients, patients that have high cholesterol, and various other chronic conditions that can affect them. In those cases, we list those as well. They add as a secondary diagnosis to our DRG groups because they are going to identify things that the patient will be complicated from care on. And they should be listed any time that there's information. So you have some examples in your book on page 552 of your Connect Smart Book, where it talks about examples of MS DRGs. And it gives some examples of splenectomies with a major complication and comorbidity versus complications and comorbidities or without. And they give some weights, kind of similar to how I showed you point systems. Everything is given a point system, which then converts to a cost. So our last piece here is just kind of the last thing about tracking that you want to identify. Keep in mind that with ICD coding, with CM coding especially on diagnoses, everything that we do tells a story. And so the last thing we learn about is our UHDDS, and of course I close the chapter, UHDDS, which is Uniform Hospital Discharge Data Set. Whew, that's a lot of words. That's why we use those nice, pretty abbreviations. So what is that? Well, it's basically just another reporting system where we're looking at information about the patient. We're tracking information about their demographics, but not their PHI. Now, I've heard of people who are concerned about information mining. And that's not what this is done for. This is where we get our reports and our research and our details about, okay, we can look at the codes, we can see how long they were admitted to the hospital for specific diagnoses. And we can break it down even further and say more patients age 60 and above had COPD with asthma and respiratory failure than patients below 60. And we know that because the information from their gender, their age, their race, where they live, information about the type of provider that they're being seen, and the type of payments, what kind of poverty levels they're in, what kind of help they have. All of this information is tracked when they're in the hospital in order to better assess risk areas for certain diagnoses, identify how much it's going to cost the insurance and the provider's office to treat that patient with this condition. And that information is then used to support documentation for new research on treatment for things that aren't being treated well, new tracks for Medicare or the OIG if they want to look at different offices and say, what should we be making better? Where are we missing opportunities to improve our patients' health and their overall wealth and happiness in life? This is used for information about risk factors. How likely is it for a patient that is 60 and above with COPD to develop things like asthma and respiratory failure? And how can we educate our patients about that? All this information being tracked is done for the purpose of providing better care and better treatment. So keep that in mind as you're looking at your diagnoses codes, not just this week, but every week as we go forward. And always remember our golden rule: if it's not documented, it didn't happen. But in the inpatient world, if we suspect it, we're going to do all the treatment as if it did. And so we code it as if it did happen, so long as it's documented that it's suspected. That's all I have for you today on this video. Make sure you check our next video out where we talk about signs, symptoms, and abnormal labs. Until next time, have a great day.